Open Fracture Guidelines by British Orthopaedic Association and British Association of Plastic, Reconstructive and Aesthetic Surgeons Audit Standards for Trauma. Background and justification. Open fractures may require timely multidisciplinary management. The consequences of infection can be great both for the individual patient and the community. Trauma networks and hospitals require the appropriate pathways and infrastructure to manage these patients, to enable optimum recovery, and to minimize the risk of infection. Inclusions. All patients with open fractures of long bones, hind foot, and midfoot, excluding hand, wrist, forefoot, and digit. Standards for practice. 1. Patients with open fractures of long bones, hindfoot, or midfoot should be taken directly or transferred to a specialist center that can provide orthoplastic care. Patients with hand, wrist, forefoot, or digit injuries may be managed locally following similar principles. 2. Intravenous prophylactic antibiotics should be administered as soon as possible, ideally within 1 hour of injury. 3. There should be a readily accessible published network guidelines for the use of antibiotic in open fractures. 4. The examination of the injured limb should include assessment and documentation of the vascular and neurological status. This should be repeated systematically, particularly after reduction maneuvers or the application of splints. Management of suspected compartment syndrome should follow most guidelines. Fifth, the limb should be realigned and splinted. 6. Patients presenting with arterial injuries in association with their fractures should be treated in accordance with the BOST for arterial injuries. 7. In patients where an initial trauma CT is indicated, there should be a protocol to maximize the useful information and minimize delay. The initial sequence should include a head to toe scanogram. This should be used with clinical correlation to direct further specific limb sequences during that initial CT examinations. There should be a local policy on the inclusion of angiography in any extremity CT related to open fractures. 8. Prior to formal debridement, the wound should be handled only to remove gross contamination and to allow photography, then dressed with a saline soaked gauze and covered with an occlusive film. Mini washouts outside the operation theater environment are not indicated. 9. All trauma networks must have information governance policies in place that enable staff to take, use, and store photographs of open fractures wounds for clinical decision making 24 hours a day. 10. Photographs of open fracture wounds should be taken when they are first exposed for clinical care, before debridement, and at other key stages of the management. This should be kept in the patient's records. 11. The formation of the management plan for fixation and coverage of open fractures and surgery for initial debridement should be undertaken concurrently by consultants in orthopedic and plastic surgery, a combined orthoplastic approach. 12. Debridement should be performed using fasciotomy lines for wound extensions where possible. Uh, there is a diagram at the end of this slideshow which shows the fasciotomy incisions. Basically, there are two incisions on both sides of the leg. Immediately for highly contaminated wounds, agricultural, aquatic sewage, or when there is an associated vascular compromise like compartment syndrome or arterial disruption producing ischemia, or within 12 hours of injury for other solitary high energy open fractures, or within 24 hours of injury for all other low energy open fractures. 13. Once debridement is complete, any further procedures carried out at the same sitting should be regarded as clean surgery. There should be fresh instruments and a reprep and drep of the limb before proceeding. 14. Definitive soft tissue closure or coverage should be achieved within 72 hours of injury if it cannot be performed at the time of debridement. 15. Definitive internal stabilization should be carried out when it can be immediately followed with definitive soft tissue cover. So, internal stabilization should only be carried out when it can be immediately followed with definitive soft tissue cover. 16. When a decision whether to perform limb salvage or delayed primary amputation is indicated, this should be based on a multidisciplinary assessment involving an orthopedic surgeon, a plastic surgeon, a rehabilitation specialist, the patient, and their family or carers. 17. When indicated, a delayed primary amputation should be performed within 72 hours of injury. 18. Each trauma network should submit appropriate data to the TARN monitor its performance against national standards and audit its outcomes. All patients should receive information regarding expected functional recovery and rehabilitation, including advice about return to normal activities such as work and thriving.